When we set out to try and put together the research programs for the early stages of this process, we had a notion that things would be very much divided between a more like between mobile phone technology. No, sorry, I wasn't going to say anything about that. We thought it was going to be much more dichotomous, but of course, as the projects emerged and developed, we realized just how synergistic the two sides were. My interest and the interest of my colleagues has been very much about questions around what specifically is needed and how well do different interventions work. So it's trying to populate that other part of the story, not only what are the underlying processes and needs and the unmet needs, but how specifically can we most usefully try to understand what things should be done, how they should be done, when they should be done, and who should do them. Anyone who knows me knows I'm never as happy as I am when I see a large quantitative data set that we hope will confuse and dismay all other comers, because that is all about trying to get a better understanding of what is needed and what works and what are the problems there. Phil referred to the chronic niceness of palliative care, and I think that's luckily in the decline. I think people are remaining nice, but not perhaps so chronically nice as they were, in the sense that people are now asking more difficult questions. If we have this problem, how best do we try and meet it? The research I'm going to be talking about briefly, of course, was done across the three centres that were mainly involved in this, at the Queen's University in Belfast and at the University of Limerick, as well as ourselves at Trinity. So I'm going to talk briefly about why we chose to do these projects, a very brief summary of the projects, not but to tell you much about what we did, but to try and give some idea of how they fit together and how the overall learning went, and how we can learn a bit about where we should be going after this. There remains, I think, very considerable uncertainty about what people need in palliative care and what they want, and they are sometimes the same thing and they're sometimes not quite the same thing, and what are the results of different kinds of interventions and different kinds of programs. And the research on these topics obviously faces very practical problems because there are both practical and ethical issues in how you gather the appropriate data and how you get access to the research settings that we need to get to. Now, we had three main focuses in this, and I think each of them are illustrative of the issues involved. Cachexia is a very serious problem that many people near the end of life, particularly those with cancers, very often encounter. And it's very distressing not only for the person themselves, but also for the families that are trying to care for someone with this problem. We know also that it's a problem that's in general quite poorly managed, and particularly poorly managed within the household, and causes very serious distress. So this project was trying to see whether we could devise an educational intervention that would try and help families to cope with this problem and cope with it better. And it was interesting because we were trying to find out whether you could feasibly do this in the context of working with people who were at that time managing the problem in their own homes with their own loved ones and their own families. And I think we learned quite a lot, as we'll find out later, about how well this intervention works. But also we learned a lot about the difficulty of trying to get participation in research from people who were in this particular form of stress. And funnily enough, it was almost more difficult in this case than we've had in other cases where we're trying to work with people near the end of life who may in fact have sort of time on their hands and actually be quite keen to participate. And there are some very subtle issues, I think, around who can and cannot usefully contribute to research in these kinds of circumstances. Delirium is again an issue that's very common in the end of life, and again a problem that is often very poorly managed. People's capacity to care for themselves can be very much undermined by this problem, and the requirements in terms of both formal and informal care can be very much affected. But it's also very closely related to depression, which is often undiagnosed and some of the problems that we face is that people have not been recognized early enough to have these complex problems. And this study was aiming to get a better understanding of how best to tackle the problem of delirium, and particularly to try and see if we can diagnose depression more effectively in this population. One of the outcomes of this was a tool that's been developed to try and do better diagnosis. To try and pull all these ideas together, we also ran a project, again you'll be hearing more about this, that was trying to find out more about what people actually wanted and what they needed, and what were the styles of delivery of service that met their needs best. And so we were trying to get a better understanding not only of what people appeared to need, but what were their preferences within what they needed, and can we understand better what was more important to them and what was less important to them. What the findings, I think, reinforce from this part of the program is that getting good access and getting unfettered access to care is often just as important as what you get access to. Often we don't know exactly what is going to benefit the person most, but we do know that processes getting access can be very, very distressing and cause very serious problems. And any of us who have been personally involved in trying to broker care for someone near the end of life will really recognize a comment that I loved that came out of some of the work we did, and that was, it's bad enough to be dying, but you shouldn't have to deal with this shower. And it was very much that whatever you wanted, the answer was no, or not yet, or not until after you die. It was that kind of being pushed back, being unwelcome. And people have a huge enthusiasm for help in getting at least better access to better advice and better support, even if the final answer is we can't do very much to help. At least that feeling of being supported rather than being unsupported near the end of life. There's a few things I think we can learn overall from the experience of these projects and give us some sort of pointers to where we want to go. We know that better studies around what is useful, how well things work and so on can be hugely important in getting priority for resources to support this area of work. But we also know that there are real difficulties sometimes in setting up these kinds of studies and trials. And one of the bits of learning we need to do, I think, is to get a better understanding when you can and how you can better do these kinds of work. The cachexia and delirium studies did demonstrate how poorly some of these needs are met and how complex some of these needs are and how difficult it is to get appropriate packages of service there. And the work on preferences showed that how we meet needs is sometimes just as important as what we do when we're meeting the needs, the process, the experience that way. We also got some practical learning about how best to carry out these types of research, and there are some papers will be coming out, I hope, in the next period that will be looking more at some of these practical difficulties and guidance we can do. But we also found that in general, a lot of the worries people have about doing research in these very complex and very sensitive areas were not really as serious as people thought. The enthusiasm to participate was much higher than you might well expect. And we do recognize that we do have to be very careful, obviously, in working with very vulnerable populations, but at the same time, a lot of those vulnerable populations want to be included in research and are enthusiastic about participation. And we do need to remember that people have a right to be offered participation in research as well as a right to decline that participation. So I think we've learned quite a lot about where to go next. We know that there are still huge areas of uncertainty, and we can contribute to those areas of uncertainty by constructing good evaluative and measurement type research projects. We know that we need to expand the evidence base if we're going to translate the learning from what are the unmet needs into better strategies for meeting those needs. We need to move closer, I think, to those researchers who understand the detail and the very micro-level questions around how best to identify the problems and how best to meet those problems. And we also know that it is feasible to include people even in some of the most vulnerable circumstances in this kind of work. Thank you. I hope the videos will fill out some of the ideas and the issues that came out of that.